Okay, so I've researched acquired apraxia of speech and have looked into the clinical implications of this disorder and how it relates to our field of speech language pathology, specifically in the acute care setting. This presentation aims to provide a general understanding of acquired apraxia of speech and what roles the speech pathologist plays in their diagnosing and treatment. Apraxia of speech is a neurological speech disorder that impacts the ability to plan sensory motor actions needed for producing normal speech. This disorder is unique, but it can be difficult to diagnose as it often shows similar signs and symptoms of other motor speech disorders. Differential diagnosis between apraxia and other motor speech disorders is common in the acute care setting, and speech pathologists in the setting need to be prepared to make the correct diagnosis and therefore provide the correct treatment. In the acute care setting, speech pathologists would be part of a case for someone with apraxia, and they need to know how to differentiate this disorder from others and pay close attention to the etiology of the speech disorder. We also need to look at the characteristics of apraxia. We need to know and understand the signs and symptoms, what it looks like, how it sounds, and how to diagnose it. Lastly, we need to work with the patient and their families to get the right diagnosis in order to set functional goals and have them move to the appropriate next level of care for that specific client, because this disorder will not look the same for every patient. So every patient needs to be treated as an individual and look to see what the correct next level of care would be for their specific symptoms and severity. In the article titled Apraxia of Speech, Concepts and Controversies, they look at original and dated and a little bit outdated articles on apraxia of speech combined with more recent findings to show the change in perspective on motor speech disorders and specifically apraxia. The three perspectives they looked at included apraxia of speech as a disconnection of phonology from motor execution, motor memory, which sees apraxia as a disturbance of learned motor routines, and lastly, fine motor skills with an incoordination of spatially and temporally patterned speech movements. All three perspectives note the problems of distinguishing between three stages of being phonological encoding, motor planning, and motor execution. There are, however, interruptions in all three perspectives. In the disconnection perspective, there is a bit of a blurred boundary between the stages of phonological encoding, motor planning, and motor execution. In the motor memory perspective, there are potential confounding issues between acquired aspects of motor execution skills, phonetic plans, and knowledge about the phonological structure of a speaker's language. In the fine motor skill perspective, there is not really clarity of the distinctions between the ease of articulation as a determinant of the strength of motor speech motor plans. These perspectives show that there is really no true understanding to describe how our stored word form representations are transformed into actual speech movements. They were defining that some of the obstacles that present from understanding the links between phonological, apraxic, and dysarthria sound production impairments is seen because the existing theories cover either the phonological or the motor end of the hierarchy instead of taking both into consideration. So in the future, in order to understand apraxia of speech fully, there needs to be studies done that look both at the phonological and motor speech impairments together. In the article titled The Diagnosis and Understanding of Apraxia of Speech, Why Including Neurodegenerative Etiologies May Be Important, they looked to discuss apraxia specifically in degenerative diseases and how this will help the general diagnostic concepts and enhance the understanding of apraxia of speech and its characteristics with neurodegenerative versus non-neurodegenerative diseases. The method included looking at the current understanding of clinical features and the neuroanatomical pathologies and how it correlates to progressive apraxia of speech, otherwise known as PAOS. It looks at the similarities and differences between PAOS and stroke-induced apraxia. Conclusions note that progressive apraxia of speech should be distinguished from primary progressive aphasia, which is important to clinical care provided by speech pathologists as well as neurologists working with these types of patients. Progressive apraxia does not follow a vascular distribution. The cortical pathology is primarily in the premotor and supplementary motor area, and its onset is slowly progressive. Apraxia of speech can be the only or one of the most prominent signs and symptoms of a neurodegenerative disease, so it is critical to make the distinction between apraxia of speech from non-degenerative diseases and progressive apraxia of speech to make the correct diagnosis and provide the appropriate care. Acquired apraxia of speech is most commonly caused by a left hemispheric stroke with an infarction or hemorrhage to the left middle cerebral artery. Crossed apraxia of speech refers to a right CVA, which can cause apraxia, but it's just not as common as a left CVA. Traumatic brain injuries can cause apraxia, brain tumors, and neurodegenerative diseases, where, as mentioned, apraxia can be the first or most prominent symptom of this type of disease. With localizations, since about the 1990s, there's been inconsistency in neuroanatomical findings, and as of recently, there's been a consensus made that apraxia occurs after lesions to the anterior persylvian region, which is dominant in the left hemisphere. But all of these areas noted on the slide have been seen to have been affected, and if they've been affected, then the patient often shows signs and symptoms of apraxia as well. So signs and symptoms of apraxia of speech include segmental impairments, prosody impairments, and speech behavior impairments. Segmental impairments include phonological errors, which can be categorized by substitutions in sounds, lesions, which take out sounds within words, additions of sounds within words, sequencing errors such as anticipations, perseverations, or transpositions, such as saying bayback or playback. Just kind of messing up the sounds and the orders and repeating some sounds in there. Or they can even have voicing errors where they have a hard time distinguishing boundaries of voiced and voiceless consonants. For prosody impairments, there's a disturbance concerning the flow and melody of speech, and almost always you see a slow rate of speech in apraxic patients. They can show scanning speech, which includes the segregation and equal stress on syllables, so they might sound a little bit monotone with the equal stress. Their prosody could be affected by articulation prolongation. Prosody can also be affected by disruptions of speech flow, including self-corrections and unfilled pauses. Speech behaviors are a part of this and part of the signs and symptoms, especially because with this disorder, there's a high awareness. So these patients, they kind of hear what they're saying, they know it's not right, which can be really frustrating for them. This can be seen with articulatory groping, self-corrections, effortful speaking, and effortful speaking can lead to exertion of the facial muscles and increased loudness, which can cause other issues down the road. It is often these patients that are dissatisfied with their speech performance, and because of that, it might require some extra counseling to see how they're doing, see how they're feeling about, how they talk and the way they talk, and if they're having, issues there psychosocially. So it is almost more common than not that there are co-occurring impairments along with apraxia of speech. Some of the most common impairments that are co-occurring with apraxia include aphasia, which is a language expression and or comprehension deficit, dysarthria, which is a motor speech disorder characterized by neuromuscular speech movements due to weakness or paralysis, spasticity, incoordination, involuntary movements, or reduced range of motion. Nonverbal oral apraxia, which is the difficulty programming oral facial muscles for non-speech movements. Apraxia of swallowing, which is the difficulty programming the muscles of the head and neck for coordinated swallowing. Limb apraxia, which is the difficulty programming purposeful limb movements, and various degrees of right-sided weakness and spasticity are often seen as mostly it's strokes that are causing apraxia, which goes along with the weakness and spasticity. So when assessing and diagnosing apraxia of speech, you need to be sure to rule out dysarthria and aphasic phonological impairments, which can be difficult, but commonly used as differential diagnoses. You can also assess the severity of the impairment, looking at all the symptoms specifically for apraxia, such as the segmental impairments, the prosody impairments, and the speech behavior, as mentioned before. But it's also important for a speech pathologist to look at the general communicative abilities of this patient, to see how they might do in the long run, what kind of strengths they might have, and not just looking specifically at their speech sound abilities, but kind of all their communicative abilities. And then you also want to look at the impact of their current impairments on their quality of life and how it relates to their premorbid social roles and abilities and kind of the psychosocial aspect of their disorder. So the methods for assessing with spontaneous speech, this is where the clinician evaluates speech apraxic symptoms in natural conversation to investigate the general communication abilities, including their nonverbal communication, which is important for seeing how they're getting their message across and how they're communicating just on a normal conversation that you have with them. And then systematic assessment, that assesses factors influencing apraxia speech systematically using speech materials, which might be, normed standardized tests. Here you would use repetitions of words with varying lengths and syllable complexity. And the clinician should be able to use both methods of assessment in order to make their diagnosis and functional goals. The World Health Organization's International Classification of Functioning, Disability, and Health tells us to assess the body functions and structures, which can be done by using the Western Aphasia Battery, which assesses language function of adults suspected with neurological disorders. This helps give a baseline performance, which can be compared to when therapy started. Activities and participation can be assessed with the Assessment for Living with Aphasia Second Edition test, which is a self-report measure of aphasia-related quality of life disorders. So this really looks at the quality of life and, again, that psychosocial aspect as well. And then environmental and personal factors can be tested using the Communication Confidence Rating Scale for aphasia, which is one of the only scales that assesses communication confidence. And because, again, they're so aware of their disorder and how they're speaking, this is really important to look at their communication confidence. The goal of intervention when following the World Health Organization's ICF framework utilizes strengths and addresses weaknesses as well. The weaknesses and the strengths are related to the underlying structures and functions that affect communication to help the individual achieve the highest level of independent function of participation in daily living. This can be done by addressing barriers and make any accommodations necessary. The main goal should be to improve the speech intelligibility with apraxia, and if needed, it is possible to introduce different AAC in the forms of gesture, sign, or any communication boards if available in your acute care setting. This would be done if they are so unintelligible that they really can't get their message across and really no one has any idea what they're saying, and this can be used to kind of aid in your assessment and beginning stages of therapy while they're still in the hospital. So in conclusion, apraxia is seen in many types of patients with many different types of etiologies, and it's really important to pay attention to each individual because this disorder never really looks the same between two people. Differential diagnosis is the key in working with this population, specifically in acute care. If someone comes in with a stroke, you need to be able to rule out different motor speech disorders or even see if there's multiple speech disorders going on to be able to identify both of them or rule them out using differential diagnosis. Current research encourages the differentiation of progressive apraxia of speech from just apraxia of speech in non-degenerative diseases. So it's really important to remember that as you're making your differential diagnosis in the acute care setting or any setting that you might be working with apraxia. And every patient is different, and we must prepare them and their loved ones for their next level of care, whatever this might be specific to that particular patient.